Okay, this is going to start chapter 13. We're going to go over fluid and electrolyte and um, the electrolytes, the fluids, and the acid-base imbalances during this chapter. I'm going to break up the videos so that you have the fluid and electrolyte one first, and then acid-base will follow. And the topics that we're going to cover in this chapter, you have to know this stuff. You've got to learn it. You've got to commit it to memory, because every single other disease process that you will encounter in your nursing practice, this will relate to. So no matter what the disease process, a patient can still have some kind of fluid, electrolyte, or acid-base problem that you need to, one, identify, prevent it when possible, and correct it as soon as possible, so that you don't create other problems for your patients. So we're going to be, this time around, we're going to be in chapter 13, and it starts on page 237 of your book. A couple of things I want to point out that you should know in the definitions, if you don't already. Now, some of this stuff you should have learned from pathophysiology and stuff, but we're going to go over it. Acidosis and alkalosis, we're going to talk a little bit about that in the next segment when we talk about acid-base imbalances. The terms active transport, diffusion, and there's another one, osmolality and osmosis. Those are important concepts to know, because all of those things are used to maintain homeostasis. Your body is very gifted, your patient's body, at trying to maintain homeostasis. There's all kinds of mechanisms in place that will work very hard to return a body to a state of homeostasis, meaning a happy state of equilibrium where all of the systems are acting exactly as they're supposed to be. And your body will work very hard to do that, and often will one system will compensate for the other system if it's running into problems or disturbances. And one way to do that is through the process of osmosis, diffusion, osmolality, osmolarity. And basically that means most membranes in your body are semi-permeable, meaning they will allow some things through and keep other things out. So osmosis is the process of water diffusing across a membrane. Diffusion is the process of solutes going across that membrane. Sometimes your body has to use active transport, meaning it uses energy to transport larger molecules across membranes. This happens a lot in the cardiac muscles every time your heart beats. But each one of those things occurs because it's always trying to get to a state of equilibrium and balance. So for example, and there's a pretty good picture in your book, on page 240, it shows you a good example of how the body tries to get to equilibrium. So if you've got more solutes on one side of a membrane and less on the other, either the solutes will pass through the membrane or the water will pass through the membrane, so that both sides are equal. Your body will always try to do that. So that's sort of an important concept to keep in mind as we go through this, because it really comes into play when we're talking about IV fluids. And you need to know if the solution is hypertonic, meaning more solutes than at an homeostasis, isotonic, meaning exactly in an equilibrium state, or hypotonic, meaning less solutes than what is expected in a homeostasis state. So we're going to talk a little bit about that, but you need to make sure that you understand those concepts. Okay, the next thing I want to talk about, is it on here too? No, I guess not. We'll talk about that a little bit. Okay, so some other fundamental concepts that you need to be aware of are the different spaces within the body where the fluid and electrolytes can occur. And this gets a little bit tricky. So you have two major areas in the body that we're going to talk about that have fluid. So one is the extracellular fluid, the ECF. You'll see it in your book as ECF. So this is our cell, and this is inside the cell is your intracellular fluid. This is inside all the cells. Any cell, any organ has cells, and obviously your skeletal muscle contains the largest amounts of cells just because that's one of the biggest organs, but you got skin cells, kidney cells, lung cells, every single organ has cells. So you've got inside the cells have fluid and outside the cells have fluid in here. So these are the two compartments where fluid and electrolytes live. Beyond that, you have vessels. So these are blood vessels. So you also have within the vessel, it's called your intravascular space. Your intravascular space is going to be inside these blood vessels. Okay, and so inside the vessel, you also have red blood cells, which those are the cells inside the vessels. And so you also have things that are outside the cell, but inside the intravascular space, but not necessarily inside a cell. And those are things like water. You have tons of water. Water changes with age. Little babies have a ton of water content. Their bodies, I think, are like almost 80% fluid. Once you hit, like adolescence to middle age, it's about 60% fluid, water. And then the elderly start decreasing from there, where they get to, to 50% water, which is why you're going to see some changes in the elderly and their skin turgor. Elderly people don't have, like when you tint their skin like this, it doesn't have the same tinting, it doesn't have the same turgor, and that's somewhat because of fluid loss. Okay, so you have other things in this intravascular space like water. You've got glucose that hangs out in here. And you remember that you've got glucose is in your bloodstream, and you need insulin then to get it into the cells. So this will be our little kidney here. We've got these are all kidney cells, but the glucose is in the intravascular space. We need to get it over here because that's the energy that's being used. So you have insulin floating around in here. Hopefully if you're not diabetic, but we're going to talk about that in a couple weeks. And so then the glucose is going to transfer into cells, but these things like water and glucose, sodium is another one, and we'll talk about this in a minute. Sodium is your major electrolyte that is outside the cells. Potassium is your major electrolyte that is inside the cells. So anyways, those are just some words that you need to know. Intracellular fluid, extracellular fluid, intravascular fluid. Now, there are some other compartments where you have fluid. This is where the majority of it occurs, but you do have some, like in here, it's called your interstitial space. Interstitial, I-A-L, space. You don't have a ton of fluid in those spaces. Things it's just the lubrication between the vessels and the organs. It's just a thin layer of lubricant. The lymph system is outside of the intravascular space. So you've got a lymph system, and your lymph system is connected. You've got lymphs everywhere. You've got a ton of lymphs in your neck that you can feel. If you feel up here, you'll feel those lymph nodes. Some in your axilla, you've got some in the groin, and they're all connected. And what the lymphs do is it's just a drainage system. It drains fluid. So there's some of that. There's cerebrospinal fluid that coats the brain and up and down the spine. That's a little bit of fluid that's not intravascular or intra or extracellular. So this concept is important to know because sometimes you can lose fluid in the intravascular space, but it's not necessarily leaving the body. And that's called third spacing. So water which is supposed to be in here, for some reason flows out of the intravascular space and starts flowing over here. Well, what happens then is edema. So you've got your patient, let's say this is their, it's a really horrible foot. Let me try that again. Okay, I was going to make it a foot. Okay, so here's your patient's foot. It's still horrible, but it's going to be a foot. So it's supposed to be in the vessels. And you remember, and we'll talk more about this in the vascular stuff, but you've got, you know, your aorta comes off of the heart, and then those arteries start going like almost like the roots of a tree, where, you know, those first branches are bigger and it gets smaller and smaller and smaller, way down to this capillary level, which now it's almost like one cell membrane across. It's really, really tiny. So the water, which is supposed to stay in for some reason, is not staying in. And so then it just starts puffing up. Because it's not in the vessels, it's not going down to, you remember, the way down here at the very end, these are where the capillaries occur. So the arteries are going down to all of these spaces, dropping off the oxygen, picking back up the carbon dioxide, and it goes back up into the veins, carrying carbon dioxide. The veins then dump into the lungs, you exhale carbon dioxide, and that is the byproduct of the work of the organs. Same concept as when you eat something and your body doesn't need the food, then you excrete it in the feces. Same concept is when you blow off carbon dioxide, that's the byproduct of whatever your organs don't need. So that was kind of a side note. So then when you have a situation where your patient is third spacing, you're going to start noticing edema, but you're also going to notice signs and symptoms of hypovolemia because you don't have as much fluid in the intravascular space, even though the patient's weight might be going up. And another thing to keep in mind, and that's why we weigh patients, and the weight is such a good indicator of fluid volume status. Usually when your patient gains about 2.2 kilograms, that's equivalent to about 1 liter of fluid, which is why we check weights on our patients so often. But sometimes some hypovolemia signs and symptoms are going to be things like increased heart rate, thirst, dry mucous membranes, decreased central venous pressure, and we'll talk about that during hemodynamics. You could have dropping blood pressure. So those are all indications of hypovolemia, tachycardia, because your heart is trying to beat faster to get the same amount of cardiac output out. So those are all signs and symptoms of hypovolemia, even though you've still got the same amount of fluid in the body, it's just in not the right spot. So and another reason that you might have hypovolemia would be obvious things like trauma, where somebody is exsanguinating. Like if there is a lot of blood loss, you're going to lose a lot of fluid in the intravascular space. That's going to cause hypovolemia. Yeah, and burns are a big one because burns just kind of ooze and weep fluid everywhere. Those patients are at very high risk for hypovolemia, and burn patients are also at high risk for third spacing because the vessels get damaged and the fluid exits the vessels and it's not effective. So even though you have fluid in the body, if it's not in the right spot, it's not effective. The other things that I wanted to go over is you need to know the difference between a cation and an anion. And I'm sure you studied this when you guys took physiology, but there's some that you have to know in healthcare. So the way that I remember this is cations are like little kitties, and everybody likes a nice happy little kitty. So the cations are the positive ones. So you have cations. Those are positively charged electrolytes. If you'll remember back to your chemistry, an electrolyte is something with an electrical charge to it. So we have a lot of things in our body that don't have electrical charge, like water and glucose. They don't have electrical charge, but a lot of the electrolytes do. So you've got positive charges, those are your cations, and you have negative charges, and those are your anions. Once again, it's like a magnet. You always need the two to kind of balance each other. Here's the thing you need to know. your major cations. All right, let me show you how this works. This is my vessel again. This is my blood vessel. These are my cells inside my blood vessel, okay? The major extracellular cation is sodium. Major, okay? So this is floating around out here, and there's a lot of it. Now, keep in mind, when we draw blood on a patient, and you'll do like a venipuncture, you draw blood, and this is my little syringe, okay? And you're pulling out this fluid. You're not going right into the cell, you're pulling out serum. So when we are assessing these values, we're looking at serum, which is predominantly extracellular fluid. So these are the normals in the extracellular fluid. There are diagnostic ways to look at something inside the cell, but it's a little bit trickier and takes more time, so nobody does that. So what I'm going to tell you, these normals are what's coming out of the serum, and the major cation in the extracellular fluid is sodium, and your normal sodium, you have to memorize these, is 135 to 145 milliequivalents. Okay, you do have some sodium inside, but it's not a lot because it's predominantly on the outside. Your major intracellular cation is potassium. Most of the potassium in the body is stored inside a cell. So that's why when you draw the serum out, there's a little bit in the intravascular space, but not a ton. So your normal potassium is 3.5 to 5 milliequivalents. These are the predominant ones. You've got to understand sodium and potassium. Those are huge. The other things that, the other electrolytes that I want you to know about, and we'll go, do I want to tell you about this right now? I'll just tell you really quick because we're going to go into more of them in a little bit of detail. The other cations that you need to know about that are the electrolytes is calcium is a major cation, and the normal for here is about 8 to 10. I think it's like 8.6 to 10.6, but just remember 8 to 10 is your normal. Calcium. Magnesium is a big one. A lot of people forget magnesium, but magnesium and potassium go hand in hand with the skeletal system. We'll talk about that in a little bit. And then chloride is a big, your cations are over here. Your anions, that you're negatively charged, you've got chloride, phosphorus, PO3, I'm trying to think of your other ones. I'll get to it if I can think of some other ones. Okay, so the other thing that you need to be aware of is when you are evaluating your patients, it's really important to assess fluid volume. And the best way to do that is weight, checking urine output, and making sure that you are getting an accurate intake assessment. So that means, like, if your patient's on an IV, you're checking how much IV fluid has gone in. If they're free drinking, how much fluid have they had? How much urine output have they put out? And then also, if they're vomiting, that's a fluid output. If they're having diarrhea, that needs to be documented in the chart. The other thing that you need to keep in mind is something that we call insensible water loss. All those things that I just mentioned are sensible water loss, meaning we're well aware of it. We're well aware of when somebody urinates and how much it is and that kind of stuff. But insensible water loss can't be measured. And so we have to assess for it. And the insensible water loss is usually it's an average between 400 and 600 cc's or milliliters a day. So that needs to get added on for our patients who are in very strict I's and O's. You have to add in between 400 and 600 milliliters. And those are things like respirations. You lose a ton of air. Like every time you breathe out, you're losing respirations. And you know this when you go outside on a cold day and you can see your breath. Those are like little water droplets that come out. Or when you're in a car and you start breathing and it all fogs up, that's because there's moisture in the respirations. And also sweat. You sweat a lot during the day, and without even like profusely sweating, just regular sweating, you're going to lose some water. Now, if you have an athlete or if you're in hot areas, now all of a sudden your insensible water loss is going to go up, and you're going to have to accommodate for that when you are managing your patient's fluids. Okay. What else do I need to tell you about this? Let's go to, let me see, I told you about regulation of fluid, osmosis, insensible water loss. Oh, another thing, go to page 241 now. I wanted to talk a little bit about specific gravities. I don't know if you guys have done this in your clinical practices, but when you go into the clinical setting or in skills lab, whatever, try to see a urine-specific gravity. And the specific gravity on in the urine will tell you how dilute or how concentrated that urine is. And that's going to give you a lot of information about the fluid volume status, because very dilute urine is very clear urine, and it's usually an indication of either normal fluid status or hypervolemia, too much fluid, lots and lots of fluid. And a higher specific gravity, usually the urine is more concentrated, more yellow or dark, and that's usually an indication of hypovolemia, not enough fluid, concentrated urine. So the specific gravity, usually it's 1.010 to 1.025. That's kind of your average range for specific gravity. When it gets too high or too low, then it's kind of an indication that we might have a fluid problem. So that's one reason that we use specific gravities. We're going to talk more about this when we next semester when we talk about kidneys, because that can tell us a lot. But I do want you to know about urine-specific gravity. The other thing that is important to know with fluids and electrolytes is your kidneys are pretty much the dominant organ that's in charge of regulating fluid. So your patients who are having kidney problems may not be able to regulate fluid like they're supposed to. Your kidneys are masters at figuring out, because they have receptors in them, they can figure out, are they getting enough blood flow? And because that's an indication of cardiac output. So if the cardiac output is sufficient, then great. Then they're gonna keep putting out urine at about 30 cc's, 30 mLs an hour is about average. But if something happens to the cardiac output starts dropping down, the kidneys recognize that it's not getting enough blood flow, then the kidneys recognize that, and it will start restricting urine output in order to increase fluid in the bloodstream. So the kidneys are masters at that. So when you're talking about fluid and electrolytes, you really have to make sure that your patient has functioning kidneys. The other things that do help manage fluid are the vessels, because the vessels in here, they can figure out how much fluid is in there and the cardiac output. And so if there is a lot of fluid, the vessels can relax. If there's not as much fluid in here, they're going to try to maintain that cardiac output, so they're going to constrict, so you have a smaller area. I'm going to explain a little bit more about that during hemodynamics, because that gets a little bit confusing. The pituitary gland, the adrenal glands, those are all the skin. Those are all other organs that also contribute to the retention or the loss of fluid. I mentioned before that you do need to be careful in your patients who are elderly. A couple things happen in the elderly that make the fluid volume status a little bit tricky. One, they lose their thirst sense. So when patients start developing high natremia, high sodium, and they start getting dehydrated or hypovolemic, a normal person will start, well, you're thirsty, you get thirsty, you're like, oh, I have to go get a drink of water. Well, that mechanism diminishes in the elderly, so So thirst isn't always an indicator that the patient is becoming hypovolemic. You can't really assess skin turgor like you could in somebody who's less than, usually around 75 or 80 years old. The skin turgor goes away. Same thing with their mucous membranes. They just tend to always have dry mucous membranes, and that might not be an indication of what their fluid status is. So you have to be a little bit more careful in the elderly. The other thing that is important in fluid regulation and cardiac output is the renin angiotensin system. I love that system. And I have a great slide. I'm going to post it on PowerPoints, and I'll talk through it on the PowerPoint. So I want you at some point before you have your test to go check in on the renin angiotensin system and how that system works. I do want to point out, I noticed something in your book. Go switch over to page 245. Do you see where it's under fluid volume disturbances? See where it says assessment, diagnostics, and finding. This information is useful, and I do need you, after you've listened to this, I do want you to go through and read the chapter so you understand exactly what we're talking about. I want to go back to the kidney thing. Remember how I said that kidneys are the main organ that assesses fluid volume? One of the ways that they do that is the serum tests, BUN, and creatinine. Because in here, like this is our vessel again, you have urea in here, and creatinine. You have both of those floating around because the kidney excretes both of these things. They excrete urea and creatinine. But when your kidneys aren't working or when your fluid volume is starting to switch, these change. So these are other values that you need to know. Your BUN is your blood urea nitrogen. That's the urea that has not been excreted, but it's floating around in the bloodstream out in here. And normal BUN is 8 to 20. Normal creatinine, that's low, it's like 0.4. These are low, 0.4 to like 1.7 or something like that, or 1.6. Those are low. Creatinine is actually a better indicator of how well the kidneys are functioning. But do you see down here at the bottom of this first column where it says that like potassium and sodium levels can either be up or low, and that could be an indication of volume status? I want to look at that third bullet point that says hyponatremia occurs with increased thirst and ADH release. There's a little problem here. ADH is anti-diuretic hormone, and so what happens is when the kidneys start assessing that the patient is hypovolemic, or dehydrated or hemoconcentrated like this, then the kidneys will excrete anti-diuretic hormone, meaning we're going to hold on to fluid. We don't want to diurese. So it's ADH. So ADH does get released in hyponatremia. However, usually people that have hyponatremia don't have increased thirst, because it says here hyponatremia occurs with increased thirst. When you have hyponatremia, it could be caused by too much drinking too much fluid. And there is a disease, you'll study this, or maybe you already did, in mental health, where some people have this disorder where they just drink constantly, like gallons of water a day. So hyponatremia can be a result of drinking too much water, but typically when somebody's hyponatremic, they are also fluid overloaded. So, and I want to explain this to you. Okay, so let me explain why this would occur. Okay. So this is our normal vessel. This is going to be an isotonic. This is an isotonic state. When your patient is in an isotonic state, all of their fluid and electrolytes are normal, within normal limits. So you're going to have your potassium is in here. That's going to be 3.5 to 5. You're going to have sodium floating around out here. That's going to be 135 to 145. You're going to have normal amounts of water, normal weight, no edema, urinating 30 cc, 30 mLs. mLs and cc's are the same thing, by the way. So if you have a cubic centimeter and a milliliter, those are equivalent weights. cc's are usually a solid, and milliliters are usually a liquid. So that's, sometimes I use those words interchangeably. And you're going to have some glucose in here, and normal glucose is 80 to 100, sometimes 110, but that's changing a little bit. So this is your isotonic state. In an isotonic state, everything is functioning and working fine. In a hypertonic, this is hypertonic state, you have too many solutes, not enough water. So typically what happens is like this. So now we have potassiums in here, potassiums in here, all kinds of sodium, lots of sodium, too much sodium, glucose, not very much. This guy has adequate water. This guy doesn't have very much water. This is a hypertonic state. More solutes, less water. This is hypertonic. And then the other choice is hypotonic. And in this condition, now we have too much water. This person is hypervolemic. This person is hypovolemic. So this person has some potassium, maybe a little bit of sodium, like this. This is hypertonic. Too many solutes, not enough water. This is a nice homeostasis person. This person has too much water, not enough solutes. And the reason is, like you can tell, if we drew some serum out, this person, because now when you draw the serum out of this person, like this, by serum I mean blood, we're just drawing blood out of their, doing a venipuncture. When you draw this amount here out of this person, you're going to get a lot of water. You might get a little bit of sodium in there, but there's just not as much. So you're going to see a reduction in sodium, reduction in potassium, increased in water. You don't really check water though down in the lab, but this person is hypervolemic. This person, you're going to start seeing things like crackles in the lungs, JVD. You're going to get jugular venous distension. You might have bounding pulses. Edema can start occurring. This is what occurs in this person. This person is going to have thready pulses, low central venous pressure, low blood pressure, high heart rate, because the heart rate's going to try to compensate for, to maintain cardiac output. So these are the different tonicities that your patient can be in. So back to my point on page 245, when it says over here that hyponatremia, because these patients are the ones that are having hyponatremia, it says that it occurs with increased thirst. This patient is not going to be very thirsty because there's already so much water. This person's going to be thirsty because there's a lot of sodium and it's triggering the body to say, we need some water. We need to get some more water in here. So this person, it could be caused if they drank too much water, but this person's not going to be thirsty. So I just want to point that out because it's a little bit weird in there, I thought, in your book. So I wanted to make sure that you guys understood that. Okay, this person is going to have an increased BUN, increased creatinine. This person will have normal BUN creatinine, remember, like 8 to 20 and 0.04 to 1.7 or something like that. And this person's will be decreased because they've got more volume in there. Okay. Now, I think that's all I wanted to tell you guys about fluid. And then I wanted to go into some of the electrolytes. Table 13.4 on page 246 and 247, that is a good table to know. I'm going to post another one as well on the Blackboard site because I think one that's a little bit easier to tell. This one, it's good, but it's a little bit complicated, and you do need to understand how to recognize what kind of what fluid abnormalities your patient is in and what electrolyte abnormalities your patient is in, and what causes them. And this one, like I said, it's good. It's just, I think, a little bit too confusing. The other thing that I do want you to know, this is important. I want you to know the table on page 13.5, table 13.5 on page 248. This is important. Okay, so when you have a patient that is in one of these states, you need to be aware of what state they're in and what IV fluids they are receiving. So if you are taking care of a patient who is in the hospital and they are in one of these states, you need to be darn sure that you're aware of what kind of IV fluids they're getting. This is why. There are certain IV fluids that will not cause any shifts in osmolarity or osmolality because they are isotonic, meaning when you give a patient that fluid, there won't be any shift of water or solutes inside or out of the cells or the intravascular spaces. There are two isotonic fluids. One is 0.9% normal saline. Normal saline is sodium chloride. Oh, because chloride, I keep forgetting, I didn't put any of these in there, but chloride is your major extracellular anion, and they go hand in hand, okay, your sodium chloride. So 0.9% sodium chloride, that's less than 1% salt. It's less than 1% salt. So all those IV bags are, it's just distilled water. That's all it is. But you can't give a patient distilled water because what would happen is the water would rush into the red blood cells way too quick and blow them up. So you kind of need a little transport in there. So that's why you have to add something to the distilled water. So IVs are cheap. It's really cheap to give somebody an IV because it's just distilled water. But then you have to add something. So the isotonic fluid is 0.9%. Don't confuse that for 9%. It's not even 1%. 0.9% sodium chloride. That's the first isotonic fluid. So if you give somebody that, so you start the IV here, and you're giving somebody some fluids in there, nothing happens. Nothing happens to the solutes. All you're doing is adding water, or fluids. So this is great if somebody is going to surgery, or you just need to keep a vein open so you can give some antibiotics, something like that. That's a great choice. The other one, oh, that's lovely, great. Hang on one second. Let me come back to this.